Hello, thank you for pressing play and taking the time to watch this talk about FASD and coding in primary care. I'm Lou, I'm a GP in Sheffield and one of the named GPs for children's safeguarding with the South Yorkshire ICB team. I've been doing some work on FASD awareness raising with an esteemed group of professionals from the University of Bristol and Edinburgh, the National Clinic for FASD and the National Organisation for FASD, and I wanted to share some of this work with you. This talk will take about 15-20 minutes, and I'd really love you to share the recording and the links and resources within it with your colleagues and teams so that we can get these messages and materials distributed as widely as possible across primary care. The slides and all the links are available to you afterwards. I'll briefly look at FASD and recap a little bit about it. We'll talk about why it's so crucial to ask and advise about alcohol in pregnancy and why it's important to code for FASD. I'll run through the newish guidance that has come out from NICE and SIGN and the SNOMED coding for FASD. And then I'll show you a little bit of the knowledge mobilisation work and the resources that we've put together for you to use and share. As you already know, FASD is a neurodevelopmental condition caused by exposure to alcohol in utero. The alcohol affects the developing brain and body, and as well as lifelong cognitive, emotional and behavioural problems, around half of people with FASD will have ADHD, and it can cause up to 400 different conditions affecting the neurosystem, cardiovascular, respiratory, vision, hearing, musculoskeletal, GI and circulatory systems, and everybody with FASD will be affected differently. It's a lot more common than you think, so more children are born with FASD each year than have autism, spina bifida, cerebral palsy and Down syndrome combined. But it's very much a hidden disability because it's often misdiagnosed or undiagnosed completely. And some research by Salford University, where they went into schools and carried out assessments, found that 1.8% of children were affected by FASD, so that's around about twice as many as have autism. None of those children in the studies had previous diagnosis of their FASD. And another study done by the University of Bristol using a screening tool suggested that rates for FASD could be as high as 17%. We have the fourth highest prenatal alcohol exposure rate in the world in England. And some studies suggest that up to 3/4 of women drink during pregnancy, with up to a third binge drinking. We know that unrecognised and unsupported FASD can contribute to really serious social and behavioural problems. But we also know that having the right assessment and getting an early diagnosis, having an individualised management plan can really lead to improved outcomes for people with FASD, with a much brighter future for them. Without this, sadly, they have very high rates of secondary problems such as poor mental health, substance misuse and criminality. So why focus on primary care when we're talking about FASD? Well, I think primarily it's because we are so well placed to give women advice preconceptually and during her pregnancy about the risks of alcohol exposure to the fetus. And that's absolutely key in preventing FASD. We can also record any alcohol consumption in pregnancy, which then in turn helps a child, a young person, get referred and get a diagnosis for FASD, which in turn then helps them get the appropriate management plan that they need. I think one of the really crucial things is how we can help remove barriers for getting diagnosis for FASD by destigmatising it. I think by remembering that it's alcohol that causes FASD, not the mother, and remembering that no mother sets out to harm her baby. Research has shown that reasons for drinking during pregnancy are quite varied, ranging from a lack of knowledge and poor advice to stress, alcohol dependency and pressure from a partner. The other thing that I think really stands out to me is that we are seeing FASD, whether we know it or not. We are seeing probably quite a lot of it presenting in various ages and in different ways. And also it co-occurs with autism and ADHD quite frequently. And getting a diagnosis and getting the right help really can reduce the poorer outcomes for people with FASD, such as ending up in the criminal justice system or dying by suicide. You could read all 26 black and white pages of the NICE Quality Standard 204, or you could look through this brightly coloured summary from National FASD organisation. So this is a summary of the NICE guidance and the 5 areas for improvement. So we've got advice, asking about alcohol exposure, referring for assessment, having a neurodevelopmental assessment pathway, and management plans. So breaking that down just a tiny bit more, is saying that women should be advised in writing and verbally that there is no safe alcohol limit in pregnancy. And when we've given this advice, we should be recording it in her notes. Pregnant women should be asked about their alcohol exposure throughout the pregnancy. And again, this should be recorded in her notes. Children and young people with probable prenatal alcohol exposure should be referred for an assessment. It also states that health services must show that they have FASD training for GPs, paediatricians, and any kind of other allied professionals, and that they've got appropriate referral pathways. There should be a neurodevelopmental assessment for children and young people with confirmed prenatal alcohol exposure or with facial features, and that people who are diagnosed with FASD should have an individualised management plan. And these are the new codes that have been agreed and introduced for us to use. So we've got FASD with facial features, FASD without facial features, and it's important to point out here that only 10% of people with FASD will have the facial features. And then the third one, which I think is the one that we're going to be using mostly in primary care, is at increased risk of FASD. At this point, I just want to point out we are not being asked to diagnose FASD. That's really not what this is about. But there are things that we can do that can help. As per the NICE guidance, we can advise women and their partners preconceptually and throughout the pregnancy that there is no safe level for alcohol in pregnancy. And we can talk about the risks to the fetus from the alcohol. I know a lot of you will already be doing this, but some of you can probably still remember when we used to advise women that it was okay to have a pint of Guinness a day as a way of increasing their iron intake. And some people are still giving advice that it's okay to have one drink, or it's okay to drink socially, it's okay to drink occasionally during pregnancy. We really want to get the message out that there is no safe alcohol level for consumption in pregnancy. To support this, Manchester came up with a Dry Mester campaign a few years ago, which is being used quite widely now. It's got lots of different resources, posters and flyers, banners, badges, all of which are free and available for us to put up in our surgeries, send things out to patients where appropriate, and also to share with your partner services, so anybody that you work with in the voluntary sector, any other organisations that would maybe be able to use this and help us get the messages out there. Anyone in the primary care team, or even like in the ARRS and network roles, can ask women during their pregnancy about their alcohol exposure. And we really want to try and be asking about this at every touch point during pregnancy and recording it. And we can offer to help women in reducing their alcohol consumption and stop drinking during pregnancy, whether that be with our support or referring them into a substance misuse and alcohol service. There's a lot of stigma, shame and guilt associated with drinking alcohol in pregnancy and FASD, and some women will find this really difficult to talk about. It is something that's frequently denied when asked, even when a woman is drinking. But in primary care, we often know these women pre-pregnancy, and we've built up the trust with them, which means they may be more willing to talk honestly and disclose their drinking to us, as long as we're able to do this in a non-judgmental and compassionate way. And I'm not going to go through this slide in detail, but these are some examples of the ways we can ask women about their alcohol consumption in their pregnancy. We're encouraging everyone in primary care to use the new SNOMED codes, either when we're made aware of antenatal alcohol consumption or when someone is given a diagnosis by secondary care. And this can be done by admin as part of a scanning and coding role, or by clinical staff when we see patients. it's really important to think about having a system in place whereby when an antenatal alcohol exposure is disclosed by a pregnant mother, that information is transferred to the child's notes upon birth. We need to ensure that a diagnosis of FASD is shared with other health professionals when we're making a referral. So not only putting that in the problem list so that it's visible, but also thinking about the reasonable adjustments part of a pro forma or a referral letter for that person. And where appropriate, we need to be sharing this in multidisciplinary settings. So things like Team Around the Family, strategy meetings, case conferences, adult social care, VARM, complex case management meetings. People with FASD want their condition clearly coded and recorded in their notes and shared with professionals when needed. This helps healthcare workers personalise their care to try and meet their needs as best as we can. And coding FASD accurately also helps us meet the NICE quality standard. Coding FASD helps provide prevalence data, which in turn can help identify gaps in the system. And this helps advocate for stronger prevention and support strategies. I've had some pushback from GPs saying, what's the point in asking about alcohol in pregnancy and raising parental expectations that getting an FASD diagnosis will help their child when there is no FASD pathway and the wait for neurodiversity services years with a lack of support and follow-up following the diagnosis. And I understand this feeling, but we can't advocate for commissioning of an FASD service without being able to demonstrate the need for it. And asking the question, raising the possibility of FASD and referring will help us do that by demonstrating prevalence and the gaps. So just a little bit about the knowledge mobilisation work that we did. We ran some workshops to try and understand the barriers to diagnosing and coding FASD because we wanted to come up with some strategies to improve this. GPs that we spoke to told us they wanted accessible guidance, they wanted specialists to make the diagnosis clear in the clinic letters, and they also felt materials needed to be accessible to the whole primary care team, not just GPs. So with this information in mind, we developed a short video and a set of infographics incorporating the new guidance and coding with clear actions for primary and secondary care. And this work has now been endorsed by the Royal College of Psychiatry and the National Organisation for FASD, and it's being shared on a variety of forums and platforms. As I mentioned at the start, all of these resources are available via the links in the slides. Here are the 3 infographics that we've made with the NICE guidance and the new SNOMED codes, and this link here is for the video that we've made, which sadly won't play in this recording, but if you click on the slides and the link, it will take you to the YouTube page. So the take-home points are to advise women that there is no safe level for alcohol consumption in pregnancy, and to document that we have given this advice in their notes, to ask at every touch point throughout the pregnancy about alcohol consumption and also to document this, to code children when they are diagnosed with FASD, and also to code possible prenatal alcohol exposure and document this clearly, and to share the information, the diagnosis and the codes when making a referral or as appropriate when discussing children and young people with other professionals. That's it from me really. Please take a look at the National FASD.org website. There's a lot of resources on there. And there's also regular training, workshops, webinars run by FASD Awareness and the FASD Network. If you would like something bespoke, contact the organisations directly and they'd be more than happy to have a conversation with you about that. These are the resources that I've used. We've got the NICE and SIGN guidance, as well as the knowledge mobilisation, infographics and video details. Thank you very much for your time today. Obviously this is recorded, so I can't take any questions, but if you would like any further information or there's anything you'd like to ask me about, please drop me an email. And unfortunately this won't play during my presentation, but if you click on this link here, there's a small video of an FASD song and some self-portraits done by young people with FASD. Thank you for your time.